Hello everyone. In this video, we will talk about access cavity preparation in premolar teeth. First, we will briefly touch upon the anatomy of each premolar tooth. Then we will describe the steps and the armamentarium required to prepare access cavities for these teeth. Let's get started. Now, the maxillary first premolar generally has two cusps, a buccal and a palatal cusp. The buccal cusp is usually about 1 millimeter longer than the palatal cusp. The crown of this tooth is wider in a buccopalatal direction than in a mesiodistal direction. Now, most of maxillary first premolars have two roots and two root canals, a buccal root and a palatal root, and usually it has one root canal in each of these roots. However, in small percentage of the cases, this tooth can have just one root, and even though you will find in this tooth or in this single root two root canals anyway, buccal and palatal. In a very small percentage of patients, this tooth can have three roots, one palatal root and two buccal roots, mesiobuccal and distobuccal roots. And in this case, it will have three canals, at least three root canals. Now, if you look at this tooth from a mesial aspect, you will find a distinguishing anatomical feature that is a well-defined developmental groove in the enamel of the mesial marginal ridge. If you know this, you will be able to know if the extracted tooth that you will have to work on in the lab, if a right or a left maxillary first premolar. This developmental groove is in alignment with another characteristic feature of the tooth, which is a marked depression called the mesial developmental depression. It's located immediately cervical to the mesial contact area, and it continues apically beyond the cervical line and joins the mesial developmental depression between the roots and ends up at the bifurcation area. This is very important to know because when you start preparing an access cavity for this tooth, if you tilt your burr towards the mesial side, you will end up with a perforation because the enamel and dentine thickness in this area is really minimal. Therefore, you have to be careful and to keep your burr perpendicular to the occlusal surface of this tooth and not to tilt it in a mesial direction. Now look at this tooth from an occlusal view. You will notice the central developmental groove that divides the surface of the tooth evenly buccolingually. At the mesial marginal ridge, it joins the mesial marginal developmental groove. Now, moving into the pulp space anatomy, the pulp chamber of this tooth is wider buccolingually than mesiodistally. You probably remember from last video that the pulp chamber reflects the external or the crown anatomy, or you can consider it a smaller version of the clinical crown. That's why you will notice that the pulp chamber of this tooth is wider buccolingually than mesiodistally, because the crown itself is wider buccolingually than mesiodistally. Because this tooth has two cusps, the pulp chamber will have two pulp horns, buccal pulp horn and a palatal pulp horn. The buccal pulp horn is usually larger than the palatal pulp horn. Now the floor of the pulp chamber is rounded and dome-shaped. It's not straight, and it's located just apical to the cervical line. If you remember the criteria of the ideal access cavity preparation, the pulp floor should be untouched and should not be damaged. Knowing that the floor of the pulp chamber of the maxillary first premolar is located apical to the cervical line, you can know, or this will help you and guide you to keep your burr away from the floor of the pulp chamber to avoid any damage to it. Now, if we have a cross section, if we prepare a cross section for this tooth at the cement to enamel junction, we will notice that the cross section is kidney shaped because of the mesial concavity or the depression on the mesial side. Now, we said that the tooth usually has two roots and two root canals, one root canal in each root. The palatal root canal and the palatal orifice is usually larger than the buccal root canal and the buccal root canal orifice. Sometimes these teeth can be heavily destructed and damaged, and we may need some sort of support and retention for our restoration. We use the root canals to add or to give us some retention for the restoration. We use something called a post, which is like a small rod placed in the root canal to give some retention to the restoration. If the premolar tooth requires a post, then we usually place it in the palatal canal, not in the buccal canal. Why? Because the palatal canal is larger than the buccal canal. The dentine and enamel is really thin in the buccal canal, so to avoid any damage to the buccal root, we use the palatal canal instead. All root canals will taper down and become narrower as you move apically. Now, this is very important in the maxillary and the mandibular premolar and molar teeth, because these roots become very thin and fragile and curved in the apical part. So when we start cleaning the root canals, we have to be careful to avoid damaging the apical part that has a curved path and they become narrow. So the enamel and dentine is thin in this area and the apical part of the roots. Therefore, we have to be careful when we do the cleaning of the root canals in the premolars. Now, if you remember Vertucci's classification of root canals, he proposed 8 classifications, and he studied premolar teeth, maxillary premolar teeth, using the tooth clearing technique, and he studied the root canal anatomy in these teeth, and he found that in most of the cases this tooth will have 2 root canals. In about 69% of the cases, the tooth will have buccal and palatal canal, while in just 1/4 of the cases, around 26%, it will have just one root canal that's located in the center of the pulp chamber, and in a very small percentage of cases, around 5%, the tooth can have 2 buccal canals and 1 palatal canal. Now, if you read studies about the anatomy of root canals and on teeth, you will find different percentages in different populations. And the reason for this is the difference in the study design. So Vertucci used, the study was done in the USA, and he used, or the group has used the tooth clearing technique to study the root canal anatomy. While in this study that was done in the Jordanian population, using just the clinical techniques, using magnification with loupes and endodontic explorer, we found, or they found, the researchers found that almost all of the or of Jordanian patients that they have treated, about 98% of the cases, they have 2 root canals, and in just 1% of the cases they have 3 root canals, and in less than 1% of the cases the tooth has just 1 root canal. So the variations in the root canal anatomy studies can be related to the ethnicity of the studied group, because different ethnic groups or patients, they will have different anatomy of teeth and they will have different number of canals, and because of the differences in the study design. So if you use the micro CT technique, you will get different results, and if you use the conventional radiographic techniques, you may find different results. Now, when you start preparing an access cavity preparation for maxillary first premolar tooth, the entry point is the cross point between the imaginary line connecting the buccal and the palatal cusp tips. So imagine a line that joins the buccal and the palatal cusp tips with the central, and the central groove will cross this line. Now your entry point is the cross point where the imaginary line crosses the central groove, and this is your entry point. And your access cavity should reflect the anatomy of the pulp chamber. And remember, the pulp chamber reflects the anatomy of the clinical crown of the tooth. So your access cavity will be oval in shape. It will be wider buccolingually than mesiodistally. To prepare an access cavity for premolar teeth, you need an endoaccess burr, which is a high-speed burr that's coated with diamond and it has a rounded cutting end. Or you can use just a normal round burr, a high-speed round burr. You also need an endo-Z burr. The endo-Z burr is a non-cutting tip. It has a non-cutting tip or a safety end burr. It is also high-speed burr. And you need the DG16 or the endodontic explorer. This hand instrument has two pointed working ends angled at 45 and 70 degrees to the shank. This will provide access to root canal orifices in all teeth. Now, the endoaccess burr, we use it in the initial stages of access cavity preparation because it has a cutting end, and because we're cutting through enamel and dentine, we need a high-speed burr because enamel, as you know, is the hardest tissue in the human body, so you need something efficient to cut through it. That's why we use a high-speed endoaccess burr. The diamond also adds to the efficiency to this burr. We also need the endo-Z burr to help with the de-roofing of the pulp chamber, or to remove the roof of the pulp chamber. The endodontic explorer helps us to locate the orifices of root canals. Now, we start the access cavity, as we said, in the central groove in the middle of the imaginary line connecting the buccal and the palatal cusp tips. We use the endoaccess or high-speed round burr for this purpose, and then we started drilling through enamel and then dentine. Suddenly we will feel a drop in if the pulp chamber is not calcified, and that means that we have reached to the pulp chamber. Because the pulp chamber is a space and it contains dental pulp, and the dental pulp is soft, that's why you will feel the drop in. Once you feel the drop in, then start the de-roofing step by moving, switch to the endo-Z burr that has a non-cutting safety end, and then start de-roofing the pulp chamber by moving the burr in a bucco-palatal direction. Then you use your DG16 to identify all canal orifices. Sometimes you will find dentine bulges at the orifices of the root canals. Then you can use your Getz Glidden to remove them if needed. Now this picture shows the steps of access cavity preparation. As you can see, the round burr has penetrated through the pulp chamber, and you can see we have, with the red arrows, they point at the roof of the pulp chamber. We use the endo-Z in a buccopalatal direction to remove the roof of the pulp chamber. The safe tip of the endo-Z burr will avoid damaging the floor of the pulp chamber. If you do your access cavity properly, you will find that this is what you will end up with, an access cavity that's oval in shape with the larger diameter in the buccopalatal direction, and two root canals that are located at the junction between the wall and the floor of the pulp chamber. The floor of the pulp chamber is undamaged. Now, if the tooth has 3 root canals, then your access cavity will be triangular, and the base of the triangle will be towards the buccal side of the tooth, because if the tooth has 3 canals, the 2 of these canals will be in the buccal side and 1 will be in the palatal side. Moving into the maxillary second premolar. This tooth looks like the maxillary first premolar with some variations. It has a less angular and more rounded crown. The crown is smaller than that of the first premolar. It usually has 2 cusps, buccal and palatal cusp. Both cusps has almost the same height. It has no mesial developmental depression, and it has no deep developmental groove crossing the mesial marginal ridge, and that will help you differentiate between the maxillary first and second premolars. Now, if we look at the pulp space anatomy of this tooth, we will find out that the pulp chamber is wider buccolingually than mesiodistally, of course, because it reflects the anatomy of the tooth. And it usually has 2 pulp horns, and the buccal pulp horn is usually larger. This tooth also usually have one. This tooth usually has 1 root, unlike the maxillary first premolar. Now, within this root, you can find 1, 2, or 3 root canals. Usually, in most of the cases, it has just 1 canal, but it can have 2 or 3. Now, the roots or the apical part of the roots of this tooth is in close proximity to the maxillary sinus. So if you look at this radiograph, which shows the maxillary right first molar, the maxillary second premolar, and the maxillary first premolar and part of the canine. If you look at the apical part of the maxillary second premolar and the apical part of the roots of the maxillary first molar, you will find that they are in close proximity or within the maxillary sinus. And for this reason, we have to be careful when doing root canal treatment for this teeth. We should avoid over extending our instruments or the root filling materials to the sinus in order to avoid a complication. Now, the Vertucci group found that almost in 3/4 of the cases of the maxillary second premolars, it has just 1 root canal. And in almost 1/4 of the cases, it has 2 canals, and in only 1% of the cases, it can have 2 buccal canals and 1 palatal canal. Now, for the access cavity preparation, it's almost the same for the maxillary, similar to the maxillary first premolar. The access cavity will be oval in shape, wider buccolingually than mesiodistally. Then if it has 2 canals, then the access cavity will be identical to what we have seen in the maxillary first premolar. If it has just 1 canal, then the access cavity will usually be smaller, and the access cavity will be triangular if the tooth has 3 canals, and the base of the triangle will be towards the buccal side because the tooth will have one mesiobuccal canal, one distobuccal canal, and one palatal canal, and then they will form a triangle with the base towards the buccal side. The Vertucci group found also that the maxillary second premolar, this tooth has the most variation in root canal anatomy, and it can demonstrate all 8 root canal configurations. So within the single root that you will have for the maxillary first premolar, you can have any of Vertucci's 8 canal configurations. So it's not an easy tooth to treat. That's it for the maxillary premolars. Now we will discuss the access cavity preparation for mandibular premolars.